jump on over to the PowerPoint here. And so this was a patient that I saw in clinic a while back, presented with lateral ankle pain. And let's see, there we go. So again, I just wanted to put these at the beginning if this helps guide your clinical decision-making, these documents where you're going through, shoot, I don't know how to admit people without stopping this share screen, so I might have to do that a couple times, so I apologize for that. But okay. That's weird how that works. All right, so I think everybody's in now. So yeah, so if these help guide your decision making, I think they're useful. Kind of an explanation about the different parts of the orthopedic exam, and then a chart for you to fill in if you want to kind of play along and fill this chart in as you go. You're welcome to do that, or if you just kind of want to listen and process and take notes and that kind of thing, welcome to do that as well. But this will kind of give you a template for your subjective information that you're trying to gather, and then your objective exam findings, and trying to make sense of, the reason I like this document and why I put it together is trying to make sense of what each of those findings will tell you as you start justifying your differential diagnoses. And then if you're looking back at your impairments, trying to link the treatments that you're selecting to those particular impairments. So again, those are there for your reference. So this case today I wanted to talk about today, and again, I've adapted information and names, and this is HIPAA compliant, so this is not exactly the information about my patient, but I did see somebody, an individual with similar presentation. So Emily is a 43-year-old female, presenting to your clinic with complaints of left lateral ankle pain. So here's our patient demographic for this particular case. She complained of left lateral ankle pain with not knowing anything else, just the age, gender, what's bothering her. What are you starting to think about for your subjective questioning for exam? So maybe what are your top 3 subjective questions that you want to ask this individual based on knowing the area, knowing her age, knowing demographically, a little bit about her, not too much. But what are you starting to think about? Mechanism questions, maybe onset, anything about pain behavior that's going to start narrowing down what structures might be involved. What are you wondering in this particular body area? Anything specifically about screening questions or red flags or need to see other providers than you? What questions might you ask for those sorts of things? And then how is this affecting her life? So what are the things she does for work? Fun. What are her goals? So you have probably more specific things in each of those categories, but just to start thinking about those. So one of the things that fits into that category that I want to take a little tangent on, because I think it's a nice review in this particular case, is a specific musculoskeletal screening procedure that might be indicated to rule out a fracture at the foot and ankle or determine the need for imaging. So if you think about what are these guidelines called, and how is that gonna change what you do in your exam. So when we're thinking about screening for fracture of the foot and ankle, we are going to be using the Ottawa ankle rules. And this is just a quick picture of those rules. And I think it's nice to have the visual and not just the words. But the upshot here is that during your physical exam, well, you're going to be asking about trauma and mechanism of injury to kind of steer you down this path. But also during your physical exam, if you do suspect a fracture, that's going to lead you to, during your palpation section, palpate at 4 specific, very specific bony prominence landmarks. So thinking, and this is all based on, this picture, these guidelines, but just very quickly to go through this, both malleoli, the posterior inferior aspects specifically, so both malleoli, and then 1 bony prominence on either side of the midfoot. So base of the fifth metatarsal, and then navicular on the medial side. Base of the fifth is on the lateral side of the foot, navicular on the medial side. So those 4 bony areas, if you have significant tenderness in those and inability to bear weight when you first have this injury and in the emergency department, then you're thinking this individual might be appropriate for x-ray to rule out a fracture. So that's a safety thing you need to be thinking about, especially with direct access. Thought it would be nice to review. So for this individual, she came in, her mechanism was not traumatic, so we may or may not screen her in that way. We'll kind of see. But what we're thinking about is based on her mechanism, she was running and she just started noticing it a couple months ago. Her longer runs, greater than 2 miles, she would notice this kind of achy pain on the right side, the lateral side of her left ankle. And she went and saw her podiatrist, and he said, "Oh, you have overuse syndrome." So it's not very specific on purpose. It kind of gives us a chance to diagnose her. She doesn't think she rolled it or stepped funny, but she's not quite sure. It just kind of started hurting, and she can't run now at all because it's kind of gotten worse and limited her running. Location of the pain is that left lateral ankle. It's kind of behind the malleolus. To the best of her knowledge, it's achy. Sometimes it's sharp, and it kind of fluctuates. So it does go away sometimes, but at its worst, it gets up to a 7 out of 8. Kind of intermittent. Walking kind of bugs her. It's worse with weight bearing. It's worse with going upstairs. She can't really run. Rest helps. So if she avoids being on her feet, if she avoids doing a lot of walking or running, it is better. And said she's tried massage. Massage makes it feel good. Like calf massage helps out a little bit. I'll let one more person in here. Sorry to disrupt. And back to sharing. Like how I audible that. It helps me with the technology, I think. So thank you for bearing with that. Okay, and then so we go through ag and ease factors. When you ask her about numbness and tingling, I don't know if she really knows what that means, but she says her foot sometimes falls asleep on the left side. She does have her past medical history. She sprained her right ankle a while back. She was in a car accident. She had x-rays already on the left ankle, so you don't have to do auto ankle rolls on her, but it's good we know about them. Unremarkable, no fracture noted on that. She does have an MRI scheduled for a couple weeks, so her podiatrist ordered an MRI. But it said, hey, go to PT in the meantime, see if you can get stronger, and then we'll see what the MRI says. And patient goals is she really wants to get back to running. She wants to get back to walking with her friend, and kind of is limited in those main things that we talked about. So going from here, we know that left ankle is bugging her. What are the keys that you picked up on out of the subjective history? So this is kind of in the notes for this slide. I want you to start thinking about what are the things, we got all the information from those different sections, but what are the things that you're really honing in on to help you start to figure out what is the tissue involved, what's her severity, what's her irritability of symptoms, what's the pain patterns? Is it consistent with musculoskeletal, or are we thinking more of a sinister pathology that we need to screen for or rule out? Some things that I noted from her subjective history that kind of stuck out to me that I really wanted to keep in mind and that helped guide my objective exam were these. So worse going upstairs versus down. If you're thinking up versus down, clinically, going upstairs, to me, this is my decision making, is that's more of a muscle effort to go up the stair versus coming down the stair. A lot of times we will note if people have pain or dysfunction descending stairs, that is a heavy eccentric load on certain muscles, for example, quadriceps muscles, or eccentrically lowering to descend a stair or to do like a heel tap exercise. The other thing descending stairs really loads is joints. So if people have knee pain, going downstairs is often worse than going up. People have ankle pain at the talocurl joint and or are limited in mobility at that joint. If you think about the descending motion of stepping down from a stair, places you in a good amount of close chain dorsiflexion, which can stress that joint or can stress ligaments at that joint that can be pain provokers. for patients. So to me, it's kind of significant that she's not only having pain on stairs, but she's having pain going upstairs versus down. So I'm thinking less joint, and I'm thinking more at this point, is there like muscle dysfunction or tendon dysfunction versus talocrural joint dysfunction or ligaments. So that's my thought process on that, is why I think that's important. That might be a little foreshadowing. Her pain pattern to me was consistent with musculoskeletal injury. So it's aggravated with mechanical loading. It's eased with rest, ice, and says, as you would expect. Doesn't sound very sinister. It sounds believable. She doesn't have a traumatic mechanism. So again, and she has imaging. So we're not trying to rule out fracture. She might not be an ankle sprain patient, though this is commonly an injury that we see at the ankle. Her foot falls asleep. So that might take a little more digging. I might want to look at that. That might necessitate more of some screening for the nervous system or nervous component. Okay. So what do we got? What are you guys thinking are your top medical diagnoses at this point in the exam? What types of tissues do you think are involved? Do you think it's musculoskeletal or not? Am I missing something that maybe is there, but I just didn't pick up on that could be sinister? It's a lateral ankle. So remember your anatomy, what is regionally there on that lateral ankle versus medial? What muscles, tendons, bone, nerve, vascular supply are potential pain generators in the lateral ankle? Okay. And then what tests and measures would you like to perform as part of your objective exam? So we took a pretty comprehensive subjective. She's told us a lot of good information, but then what do we want to be selecting? What do we want to be really picky to rule in, rule out some of these things that we have a little bit of doubt about? So for example, I'm choosing to do a neuro screen because her foot falls asleep. So I don't think it's neuro, but I want to rule that out. So I want to do the neuro screen to rule out versus rule in. So that's part of our decision making as we select those testing measures. All right, so then these are our PT objective exam findings, and I will let you know, so this subjective and objective, these tables, I've kind of distilled and placed in a PDF document on Drive, and so if you want to look at the case study in its entirety but not go through the PowerPoint, you can look at that PDF. Don't look now because it does have the medical diagnosis on there, so don't cheat ahead of time, but if you want just a quick snapshot of the case, you can look at that PDF. And that might be a little bit easier than reading all these words on the slide, but I feel like they kind of complement each other. So that's why I made a really wordy slide. I know I'm breaking the rules, so apologize for that. But it's my presentation. I can break the rules. Okay. Here we go. So key things from the objective. So she comes in, she's limping a little bit, no assistive device. She's in her 40s. Standing posture is pretty normal. She can squat. That's fine. Her single leg squat is not as good. She has a little bit of pain on that lateral ankle, a little bit of loss of stability, but nothing significant. Her neuro exam pretty much checks out. It's clean. Straight leg raise checks out. That was an additional neuro test I threw in there just to make sure nothing's going on. And then what really is informative, I think, of her exam and what I really want to focus on are her range of motion and her MMTs, so her muscle testing. And if we remember the Cyriac's pattern of diagnosis, so James Cyriac, who's kind of the father of orthopedic medicine, he has this very clean and very crisp statement that he categorizes lesions as either contractile lesions or non-contractile, meaning contractile lesion refers to a lesion or an injury of muscle and tendon. Non-contractile refers to, just like it says, lesion of non-contractile origin. So maybe it's bone, maybe it's nerve, it's something that's not going to shorten and lengthen, muscle, tendon, right? So if we're trying to differentiate between those two types of lesions, again, he has this very clean statement, and he says, contractile lesion will have pain upon active contraction and passive stretch in the opposite direction. So let's remember that pattern as we go through these active and passive motions and MMTs, okay? So pain with active contraction, muscle tendon, and passive stretch on that muscle tendon. So both of those things are going to be pain provokers. Yeah. Ty, do you have something you want to add?
Yeah, no, I was just reading through the subjective. What was her 24-hour pattern?
24-hour pattern. She didn't really have one, so it was worse. It was worse with activity. It was relieved by rest, but she couldn't really. It wasn't really worse in the morning. If she did a lot, it was worse towards the end of the day.
Okay, thank you.
Yep, good question. Good question. Okay, so right ankle, we checked because we want to check it as comparison, but there's nothing really that sticks out. Left ankle, actively, plantar flexion and eversion are pretty painful. So those motions are kind of limited by her pain. Her inversion, 40 degrees, dorsiflexion 15. So those seem pretty good. Passively, excuse me, her left ankle, we can push her into 65 degrees of plantar flexion. So we can push her down, and we can push her into eversion about 23 degrees. So again, those seem within our norms of motion, and not too bad. So it's painful when she gets there, but if I move her there, it's not painful. So what are you starting to think? What does that start to make you generate? What types of tissue? And then passively as well, those opposite motions. So if I push her into dorsiflexion and give her some overpressure, that's pretty painful. So why is that painful? It could be either the joint, I'm stressing the talar curl joint at end range dorsiflexion, or it could be stretching some sort of contractile structure as I move her into dorsiflexion. And then same thing with inversion. As I move her into that inversion and give her some overpressure, that's really painful. So it could be that I'm running into end range of joint motion, or it could be I'm stretching contractile structure. Okay, and then her MMTs, her dorsiflexion and inversion are fine. She's strong. On the right side, she can get 15 single leg calf raises. On the left, she can't because it's really painful. She can't really do a calf raise or a heel raise. Right eversion's fine. Left eversion's really painful and very weak. So that eversion motion, not doing it for us. Her joint mobility, pretty normal. So the things that we expect at a joint to check them off are kind of checked off. So again, one of the manual therapy greats, Kaltenborn, says healthy joint should be able to rotate and translate. In other words, the osteokinematic motion should be intact. So that rotational motion, we're thinking physiologic motion, dorsiflexion, plantar flexion, inversion, eversion, those should all be intact at a healthy joint. And then a healthy joint should be able to translate. In other words, the glides at the joint, the arthrokinematics, should also be intact. And so the anterior, posterior glides of the talar curl joint, the medial lateral glides of the subtalar joint should be intact, and they are. So that's making us think less likely joint, more likely soft tissue. She's really tender at the peroneals, tender at the base of the fifth. She's not tender at those other bony landmarks that we're thinking are screening points. All right, so another little tangent. What ankle injury is most common and causes pain at the lateral ankle? So which type of motion are we expecting is going to be painful? So little tangential review, and then we'll get back to the case. So most common mechanism of injury, and these are all in the notes section of the PowerPoint, but I think you guys are on board with this. Plantar flexion and inversion. So an inversion ankle sprain, most common ankle sprain, and the most commonly injured ligament is on that lateral ankle. So as that ankle comes in, it's going to stress the lateral structures, and ATFL, anterior talofibular ligament, is going to be the most commonly injured. The other structures that could be affected of the lateral ankle are peroneals, that tip of the lateral malleolus. Sometimes you'll get an avulsion fracture off of the fibula there distally if it's severe enough of an ankle sprain. So those are some other things, as well as the other lateral ligaments, so CFL, PTFL. And then a couple charts for your reference of how to grade ankle sprains. So grade 1, grade 2, grade 3. This is common at other joints as well. We want to grade severity. and we're thinking about severity based on how much swelling there is, how much ligamentous disruption, and then how much functional loss. So usually functional loss, we're thinking about weight bearing in terms of severity of an ankle sprain. So I'll let you kind of look through this, but the next few slides kind of give us a sense of, with that lateral ankle sprain, what do the grades actually mean in terms of a really tangible case, a lateral ankle sprain? So with a grade 1 sprain, you can see that, again, ATFL is most common ligament disrupted, and we can see right in here that with that grade 1 sprain, you're getting some stretching and probably some tearing of that ATFL, but it still has some intact fibers. CFL is probably a little bit tender and affected, but again, not torn. If we go to a grade 2, the ATFL, now we have a partial tear in that particular ligament. CFL has been affected, but not really torn yet. It's probably torn a little bit. Stretching, you probably have some fibers torn, but not showing a tear on here. And then grade 3, we're thinking very severe sprain. ATFL is torn, CFL is torn, and there's a partial tear of PTFL. So that kind of gives you a sense for severity of sprain, how to grade those sprains, and what structures might be affected based on that grade, lateral ankle. So what are we thinking about this individual? Well, we don't think she sprained her ankle. It's not traumatic. We've decided she has this pattern of pain with active contraction and passive stretch. She has pain to palpation at this specific muscle group. And so with this pattern of dysfunction, it really looks like she has a pattern that's suggestive of a peroneus longus and brevis injury. So it's painful to evert, it's painful to plantar flex, and then stretching in the opposite direction is painful because we're stressing those contractile structures, either the tendon or the muscle. One thing to think about when you're diagnosing these soft tissue lesions or trying to figure out the severity of these lesions is there a tear, and then how severe might the tear be? Well, you're not necessarily going to diagnose this. So the gold standard is MRI for soft tissue lesions to really detect if there is a tear and the severity of injury. But based on your clinical exam, you can start to hypothesize and you can start to hone your decision making. If there's a full tear, that might necessitate surgery versus PT treatment. And so some of the things that are going to clue you into the presence of a full versus a partial tear are these specific patterns. And this will hold true whether you're talking about the peroneus longus, peroneus brevis, or where you're thinking about a rotator cuff. A full tear of rotator cuff is oftentimes, or textbook description would be that injury might be pain-free, which is a little bit surprising. At first glance, you think a tear in something should hurt, but if there's a full tear and you're asking somebody to use that muscle and tendon, they're not pulling on anything that's injured because it's been fully separated. So the pattern that's described might be complete loss of function but no pain for a full tear, versus a partial tear, you're expecting weak and painful. Okay, so based on my findings, she's able to go through the motion, weak and painful, more likely describes her symptoms. So in my mind, I'm thinking probably partial tear or tendinopathy type presentation. And so that's going to affect my treatment and referral decision. And for me, I decided to treat. So I did not decide to refer. She was already scheduled for an MRI. So who am I going to refer to? I think she's appropriate for physical therapy. So I decided to treat. So here was what happened. Well, the patient didn't return to physical therapy. I evaluated her. She was kind of a one and done patient. Evaluated her. She wanted to wait and see what was going on in the MRI, and the MRI showed a peroneus brevis tendon split tear, partial split tear. That's kind of interesting, right? So now we have this MRI that's diagnosed the issue. We had an idea that it was probably consistent with peroneal dysfunction, but I wasn't sure whether there was a tear. There's no way I was going to make that diagnosis clinically, but the imaging corroborated what we were seeing in clinical exams, so that's kind of neat. And whoops, got ahead of myself. Based on that, there are a couple articles that I subsequently looked up, and how does this guide our treatment with herniatus brevis? So I was thinking, oh man, she has a tear. Is that a contraindication to PT? And it turns out that in some of these articles, there's not loads of research that I found on this, but one particular article is a case study, and they looked at common clinical practice and guidelines based on the research. The severity of the tear really guided treatment decision making. And if you see the simple takeaway from this table is the idea that if it's a less severe tear, so grade 1 or grade 2, that's going to point you to conservative treatment a la PT. So that's what we're trying to do. Versus a full thickness split. She did not have that. She had a partial thickness split tear, so probably a grade 2 if we were to grade it. Full thickness split or a longer split in that tendon, that would justify more of a surgical intervention. So based on that, I think trial of conservative treatment is appropriate. That's what our podiatrist said. He sent her back to PT, so I got to see her, reevaluate her. And my PT plan of care when she came back and my treatments kind of looked like this. So plan of care, I was thinking, what are prognosis? How long do I want to extend this? Type of tissue involved, we think it's tendon, stage of healing, is longer out, so it's maturation. So by the time I saw her back, she was, do I have this somewhere? Yeah, so under the notes section, basically describes what happened, but she was then in a walking boot for 4 weeks and then in an air cast. So then I saw her back about 6 weeks later, and that kind of set up our treatment. So timeline for healing, we're thinking she's now in the maturation phase. So she's let that tendon heal a little bit, but we also know that tendons take a while to heal. I'm sorry I'm kind of speeding through the end of this. We're kind of tailing towards the end. I talked a lot about that, but treatment is a little bit more straightforward. So it kind of follows this tendinopathy model of treatment, which I've described a lot. I have a series of blog posts that are in the notes that kind of describe the rationale for treating lower extremity tendinopathies. So I'd refer you to that. And then great resource is Dr. Peter Malieres. He has a whole course on treating lower extremity tendinopathies, which I've taken. It's fantastic. It's a little spendy, but if you're looking for CEUs and just some more learning information, he is a really brilliant dude. He's a physical therapist. He primarily researches tendinopathy. That's his go-to. And so this is kind of a simple way to progress treatments in tendinopathy, where you start with low load, slow speed. You progress load before you progress speed. So that's the idea with this. And so my plan of care, 2 times a week for 8 weeks. And then my treatments, I'm going to start with isometrics because her, when she's actively using that muscle, it's still painful. So let's get it to work, but at a sub-threshold load. And then we're going to progress to isotonics. Might use some modalities and some neuro re-ed. Anytime we're working at the ankle, we want to make sure that balance and proprioception is good. And so ultimately, we want to get her back to functioning with this muscle group full on board. So we want to strengthen eversion. We want to strengthen plantar flexion, but it might take us a while to get there, to get to the full isotonic loading of those areas. So that is a wrap up for this case study. So lateral ankle pain doesn't have to be an ankle sprain, even though that's the most common. I thought this was an interesting case to get us thinking about that pattern of injury for contractile lesion. And then it was also interesting to see a patient, have them go away for further testing and come back, and then be able to use the information gained from that imaging to guide treatment a little bit. And in fact, it really followed, this is kind of one of those cases where the podiatrist really recommended conservative treatment, and that followed what the literature tells us. So that was kind of neat as well. So thank you all for joining me. This is case study number 2. I would like to continue to do this, but I will let you know. I will keep the schedule updated on that Google Drive. And yeah, thanks for being here. All right.
Thank you.
Thank you very much.
Hey, Leda, I had a question about the foot falling asleep.
Yes.
Was that addressed